welcome to part 2 of this presentation on the knee. It's a continuation of part 1. So here we're going to present a range of fractures of the knee and the tibia and fibula, and also look at some of the anatomical variants.
So here we have an example of osteochondritis desiccant within the femoral condyle. If you remember back to the ankle, you can get osteochondritis desiccans in the talus. So just to remind you all, osteochondritis desiccans, the believed etiology of it has been trauma at some point, and then it's now a chronic appearance. So it tends to affect the medial femoral condyle, as it does in this particular image. And why this appearance is slightly different to the picture that I'd shown you in the talus is that what's happened is that the old fracture, osteochondral fracture to the articular surface, it hasn't completely detached and it stayed adjacent to the host bone. So you have the old non-union fracture fragment adjacent to the articular surface. You've then got the surrounding subarticular lucency, where you can see the defect within the femoral condyle, and then because it's chronic in appearance, you get the reactive sclerosis as the bone has tried to heal itself. And if you look carefully, you can actually frequently see the defect on the lateral view in comparison to the ankle, where you can rarely see the defect on the lateral ankle view. If we look carefully, you can actually see two osseous bodies adjacent to the subarticular surface, followed by the surrounding subarticular lucency. So it's important that when you check your image, you look at both views. So what is it? It's osteochondritis desiccans, where it's the medial femoral condyle and how it's undisplaced. It's important to scrutinise the intercondylar eminence because you can get avulsion fractures. If you remember back to your anatomy, the anterior cruciate ligament inserts anteriorly and the posterior cruciate ligament inserts posteriorly. In children, because their ligaments are really strong, they're more likely to sustain an avulsion fracture rather than rupture their ligaments. Whereas once you get into adults, adults are more likely to sustain a ligamentous injury rather than a avulsion fracture. So here we can see that the anterior cruciate ligament has pulled off the anterior tibial spine. Interestingly, there is no lipohemoarthrosis, but there is a joint effusion. We can tell that there's a joint effusion because the posterior suprapatellar bursa has been completely depressed. So what is it? It's a fracture where it's the intercondylar eminence. How? Avulsion at the anterior cruciate ligament insertion. So with this image, we've now got an avulsion fracture at the posterior cruciate ligament. So if you look carefully, the anterior spine has been left intact and the small fracture fragment has seen posteriorly. This is also associated with a really lovely lipohemoarthrosis. We know it's a lipohemoarthrosis because there's a dead straight line with the blood forming inferiorly and the fat floating on top, creating a fat blood fluid level. So what is it? It's a fracture and a lipohemoarthrosis, where it's the intercondylar eminence, how avulsion at the posterior cruciate ligament insertion. Tibial plateau fractures can be quite difficult to see, and that's because on the tibial plateau is not all at one level. What happens is the posterior aspect of the tibial plateau is actually inferior to the anterior portion of the tibial plateau, and because of this lack of superimposition, it means it becomes very difficult to actually visualise fractures through it. So helpfully, quite often they're associated with the lipohemoarthrosis, and that's because the proximal metaphysis of the tibia contains fatty yellow marrow. So if you do have tibial plateau fracture, it's an intra-articular fracture, and so quite often the fat will extrude out into the joint. So things to look for, you tend to get increase in trabecular density beneath one of the plateaus. Now, in the context of trauma, it tends to be the lateral tibial plateau as opposed to the medial tibial plateau. And so this increase in density, increase in sclerosis, is where the trabeculae has become impacted together. And also the other thing to look for is you get loss of alignment of the lateral femoral condyle with the lateral tibial plateau on the AP view. And we'll go into that in a little bit more detail in a moment. So on our left, we have a normal knee x-ray. And if you draw a line along the lateral margin of the lateral femoral condyle and you draw it down to the through the lateral tibial condyle, you'll find that the lateral tibial condyle is positioned slightly more lateral than the lateral femoral condyle, but it should be no more than 5 millimeters. Now let's have a look at this really quite impressive fracture of the lateral tibial plateau, and we can see that if we draw a line along the lateral femoral condyle, we can see that the lateral tibial condyle is significantly more laterally displaced than normal. It's much greater than 5 millimeters. There are 3 types of tibial plateau fractures. There are depression fractures, there are split fractures, and there are a combination of split depression fractures. With this image, we can see that so if we look at the medial tibial plateau, you've got a nice articulous cortex, and when you look at your lateral tibial plateau, we can see the sclerotic articular cortex, and then suddenly at the lateral margin, you've now got a lucency, indicating that you have a break. Now, if you look inferior to the lateral tibial plateau, you can see that there is an increase in density in comparison to, say, the medial side. And this increase in density is caused by the trabeculae crushing together, creating that increase. Now, I should just briefly comment on insufficiency fractures. So remember, an insufficiency fracture is normal load going through abnormal bone. And the most common insufficiency fracture, sometimes also called a pathological fracture, is osteoporotic bone. And what happens is patients who have osteoporosis, so are elderly, they're more likely to sustain a medial tibial plateau insufficiency fracture, and that's because as we stand, the main gravitational force actually comes down through our medial tibial plateau rather than the lateral tibial plateau. And as patients with osteoporosis have reduced number of tuberculae, what happens is that you get a collapse of the trabeculae and you get an insufficiency fracture. Now, quite often you can't actually see it when it first happens, and you can only visualize it sort of 2-3 weeks after the event. And in the same way that this patient has increased in density on the lateral aspect, if you have a patient with an insufficiency fracture of the medial tibial plateau, you'll see that increase in density there. So what is it? It's a fracture where lateral tibial plateau, how depression. And actually this is quite a good example. If you go down the lateral margin of the lateral femoral condyle and it bisects the lateral tibial condyle, it is not by much, but it is more than 5 millimeters. And here we have a really significant injury. So with this one, we have a marked splitting of the tibial plateau. It's like it's been cleaved. And we have significant comminution, and it's depressed. So if you look at the medial tibial plateau, and then if you can see how much the lateral tibial plateau has been displaced, so we have a split depression fracture. Now if you look carefully, the fracture line actually extends up into the medial tibial plateau, we can actually see a breach of the medial cortex. And if you want to draw your line down the lateral margin of the lateral femoral condyle, we can see that when it bisects the lateral tibial condyle, it's significantly greater than displaced by 5 millimeters. So what is it? It's a fracture where medial and lateral tibial plateau have split depression. Sargon fractures are caused by a rotational force while the knee is held in flexion. The thing is, this teeny tiny fracture is very, very significant because 75% of them are associated with an ACL rupture. So what are we looking at? We're looking at a tiny sliver which is usually elliptical in shape, adjacent to the lateral tibial condyle. Now, the Sargon fracture is an avulsion of the lateral capsular ligament, not collateral, the lateral capsular ligament. And what that means is it's positioned slightly posterior to the lateral tibial condyle, so you can't actually see the host location when you're looking at an AP view. You need to make sure that you don't confuse it with a tiny avulsion fracture of the styloid process of the fibular head, which is usually caused by the biceps femoris rupture. And also you can get another avulsion in this region of what's called Gerdy's tubercle. Now, Gerdy's tubercle avulsion injuries are a much larger osseous fragment, and you can see the host bone location because it's located more anteriorly. Gerdy's tubercle is not a significant injury, and it's an avulsion at the iliotibial band insertion. So what is it? It's a Sargon fracture where lateral tibial condyle, how avulsion with slight distraction. You can get fractures of the anterior tibial tubercle. Again, this is an avulsion injury. Now, this isn't a Salter-Harris fracture injury because the anterior tibial tuberosity is an apophysis. So if you remember from previously, an apophysis is responsible for increase in diameter, and it's the site of where ligaments and tendons insert. So with this injury, we can see that the tibial tubercle has been avulsed and there is distraction of the fracture site. And if you look, we can quite clearly see that the pre-patella tendon contains multiple stranding and obliteration to it, indicating that this has a really significant tendon injury. So what is it? It's an avulsion fracture where it's the anterior tibial tubercle, how with distraction. Osgood Schlatter's disease isn't actually a disease per se. What it is it's a traction apophysitis. So the anterior tibial tuberosity is frequently fragmented, and that's a normal appearance. What I mean by a traction apophysitis is that it is repetitive pulling or traction, should I say, on the apophysis that causes irritation to the prepatellar tendon insertion. And so a fragmented tibial apophysis, as I've said, is normal, but if it's associated with soft tissue swelling, then this is the clinical signs for Osgood Schlatter's disease. So as we can see, we've got the fragmented tibial tuberosity apophysis, and that's normal in appearance, or it could be normal in appearance, but it's this associated soft tissue swelling that indicates that this now is an abnormal appearance. We don't x-ray for Osgood Schlatter's disease because it's a clinical diagnosis. However, a word of caution. People with Osgood Schlatter's disease actually have a much higher risk of sustaining an avulsion fracture to the anterior tibial tuberosity. And so therefore, if a patient presents with a history of Osgood Schlatter disease and now a sudden or markedly increase in pain, then that is justification to have an X-ray to see if they have actually had a small avulsion fracture. So what is it? It's Osgood Schlatter disease, where it's the anterior tibial tuberosity. How? A fragmented apophysis, and crucially, you must mention that it's with soft tissue swelling. In clinical practice, it's always vital that when you image the long bone, you always include the entire diaphysis as well as the joint at each end. Now, fractures to the tibia and fibula are frequent, and there are two types of forces that you tend to get. So with an indirect force, you tend to get this spiral or oblique fracture of the tibia, and then you get your fibular fracture at a point removed from the tibia fracture site. So that's essentially your chondrocalcinosis injury, where you have your disruption to your bagel or your ring as such in two different points. However, with high energy trauma, what you get is you'll get a really comminuted fracture of the tibia and fibula at the same level. The biggest problem is that you get segmental fractures, and they're very frequent. And it's important to comment on whether there is a segmental fracture because, as I think I've discussed before, if a surgeon's going to put down an intramedullary nail, they need to know about that because they will need to make sure that their nail goes through the proximal portion, through the segmental fracture or the butterfly fracture, and then out through the distal portion. So it's quite a tricky piece of orthopaedic fixation there. So when we talk about a comminuted fracture, this is what the surgeon wants to know. There are multiple large fragments of bone. If you ever see a fracture where you have teeny tiny osseous fragments, then what you could describe that as is osseous debris. And that gives the surgeon a very different impression of the type of injury. A comminuted fracture is something that's very, very important because it makes fixation so much more complex. But the reason why I want you to look at this is because it has a very large segmental fracture. And so here we can now see quite clearly how it's going to be difficult getting that intermedullary nail down through the proximal portion, then through the segmental fracture, and then out through the distal portion. Remember, we always describe the distal fragment in relation to the proximal. So this is the fibula, so therefore this is the lateral border, so therefore this is the medial border. So we can see that there's marked medial displacement and there's overlap of the fracture site as well. So what is it? It's a fracture where it's the mid-diaphysis of the left tibia and fibula. How? It's comminuted with a segmented fracture, and there's a transverse fracture of the fibula, and there's significant overlap. Toddler fractures are very specific injuries that occur in, unsurprisingly, toddlers. The tibia is normally the bone that's most affected, however femurs can be affected too. And what you're looking for specifically with these injuries is you're looking for an undisplaced fracture, and sometimes the only clue is a faint lucent line which may pass obliquely or spiral around the diaphysis. In this specific case, we can see an oblique fracture through the distal diaphysis. Now nowadays we have a much better understanding of toddler injuries, and so if a patient presents with non-weight bearing and if their x-rays are normal, they are still managed clinically and they are casted and then brought back to the department for re-x-ray in about 7 days. So what is it? It's a toddler fracture where it's the distal tibial diaphysis. How? Undisplaced. You need to familiarise yourself with bipartite patella. This is a relatively common anatomical variant where part of the patella doesn't actually fuse with the rest of the body. invariably it affects the superolateral margin. And what happens is that you'll find that it's well corticated. So it's well corticated, it's rounded, we can see the adjacent host bone is well corticated as well. And what that means is that it's definitely a chronic appearance and not an acute appearance. It doesn't actually directly fit into the adjacent host bone, which indicates that it's going again a chronic appearance, because if you have a fracture, invariably that will directly fit into wherever it's been torn off. Okay, let's have a look at it now from the lateral perspective. And now on the lateral view, if we look carefully, you can see the increase in osseous density in the superolateral margin. And again, this has very non-acute features, so it shouldn't be mistaken for a fracture. It's frequently bilateral. You can also get tripartite patella, so essentially there are 3 pieces of the patella, and you can even get multipartite, so more than 3 pieces. However, bipartite patella is the most common. So what, where and how? No fracture demonstrated. Anatomical variant bipart patella noted. And finally, I'd like you to familiarise yourself with chondrocalcinosis. So chondro, pertinent to the cartilage, and calcinosis, calcification. So if we look at the image on our left, within the medial tibiofemoral joint space, we can see this rather triangular configuration. So if you think back to anatomy, we have 2 menisci, one on the lateral aspect and one on the medial aspect of the tibiofemoral joint. And these menisci are wedge-shaped discs which act as shock absorbers. So what happens in this particular instance is that we've got chondrocalcinosis of the menisci. So if you ever see a very triangular calcification, you know it's the menisci. In comparison, if we now look over at the right-hand picture, you can see this haze of calcification within the tibiofemoral joint, and this hazy calcification is actually chondrocalcinosis of the hyaline cartilage. So it's something that you need to be familiar with. It's not an acute appearance. You see it a lot with patients with osteoarthritis, and you also see it with patients with calcium pyrophosphate dihydride deposition disease, CPPD. But it's just something that you need to be aware of.